This conference will now be recorded.
Great. Okay. So I want to welcome today Dr. Jeffrey Greenfield and Dr. Petra Klinge. And we have a really interesting Q&A session today, really focused on tethered cords. So a lot of the questions that were sent in were pretty specific, even to some other conditions. So I'm going to try and find a way to make them a little bit more tethered cord centric. And if we have other questions, maybe for another Q&A session, you can definitely come back because we're going to keep answering them as long as we are all stuck at home. So, and probably after, because this is turning out to be a really, really great thing. And I hope you all are getting something out of this. I know we are. Okay, so with that, hi, I'm Caitlin. I should probably start there. I work for Bobby Jones, Chiari, and Syringomyelia Foundation. I run a lot of the research and the program stuff. And today we have with us Dr. Jeffrey Greenfield and Dr. Petra Klinge. And I think I'm going to let you guys kind of introduce yourselves because it's probably a little easier than me doing it for you. And just to remind everyone, this is being recorded, so your video will pop up. So hello, Cheryl. No worries. I know you're just joining, so. Okay, so I will turn it over to Dr. Greenfield first.
Great. Well, first of all, thank you so much, Caitlin, for organizing this again. We had done a question and answer a month ago, and I felt like we just barely scratched the surface of so many of the questions that got asked the first time that it would be really wonderful to make this maybe more of a recurring opportunity for so many people who are out there looking for questions, and particularly given how difficult it's been to travel to see doctors and how nice a medium this has been. I think this is hopefully going to become part of a regular program for Bobby Jones CSF. So thanks for doing it and hosting it and getting all patients signed up who are interested in this topic. So I'm a pediatric neurosurgeon at Weill Cornell. That's in New York City. And I've got a long-standing interest in Chiari and Syrinx and tethered cord, obviously, and became one of the scientific advisory members of Bobby Jones CSF and started doing all these wonderful events with Caitlin and her team. And when I was thinking about the next topic and tethered cord kept coming up, I thought it would be a really fun opportunity to bring in one of the world experts in this and to introduce, to bring Dr. Klinge in and maybe throw a different format here so that people can, recognize that there are lots of different viewpoints and opinions on how to manage things. And Dr. Klinge and I discuss these things, and we share patients and we discuss at conferences. And I think sometimes patients feel like, there's, you're choosing between, who to go to. And in reality, we're all still learning from each other. And I view this as an opportunity for us all to learn from each other and to learn from the patients. And so I was really thrilled when Petra agreed to do this with us. And so I'll let her introduce herself, even though I've given her an intro. And I think this could be a fun night. So thanks for coming.
Well, thank you so much. I also want to thank the Bobby Jones CSF Foundation for organizing this. I think it's a great way to, also communicate besides what we are already doing. I want to thank Dr. Greenfield that he invited me to join. And certainly, yes, I second what he said. And we are in this together. And I see each other as partners in this. And we educate each other. We learn from each other. And by the questions you ask, we are stimulated. And it kind of like encourages our research that we're doing, because you would just have a great mind and you challenge us. But that's a good thing, because that helps us to step up and think further from what we, learned in medical school. Anyways, I'm looking forward to this evening, and thanks again for joining. I see a lot of people joining. That's encouraging, and thanks again, Jeffrey. I'm looking forward to this.
Excellent.
Thanks so much. Yeah.
Well, so I'm going to kind of dive in first. There was actually a question that came up, and I think you guys can kind of tag team this. It was really about the definitions. So what exactly is a fatty phylum? And what is the difference between just a fatty phylum and a true blue tethered cord? So I don't know who wants to take that first.
How about we alternate going first? I'll start and then every other question so we keep it balanced. So I think this is a really great place to start for everybody because I don't know if Caitlin meant to do this, but I think it really opens up an opportunity for us to lay out some definitions because I think patients will very commonly conflate terms and tethered cord and tethered cord syndrome are an enormous spectrum of disorders that sometimes all get lumped into inappropriately into one small category. And so the first thing that I want to make sure that is clear to everyone that's on here and that is that tethered cord and tethered cord syndrome are sort of distinct from each other in the sense that one is a radiographic or like a physical finding, and one is a constellation of symptoms and signs. And so if we ask what is a tethered cord, then that in itself is a huge spectrum from very, very simple things, such as, you know, the very tight phylum that we see in occult tethered cord, which you don't even often see on MRI, to lipomas, fatty phylum, or the phylum has fat within it, to the more complex types of tetherings, which are lipomeningoceles, myelomeningoceles, masses within the spinal column where the degree of difficulty and the degree of complication and risk is way different than it is for the more simple forms of tethering. So I want to caution everyone throughout the night, because I think this happens to me in so many of my visits, that the data for tethered cord and the data for complications and the data for retethering and the questions that I get asked all the time are often pooled together from, you know, wide variables in terms of these different types of tethered cords and different patients and different risks. And so the numbers that you get, and patients will often tell me, well, I heard there's a 2% risk and someone else told me there's a 20% risk, and the numbers are really difficult to assume. And that's why, you know, doctors like Dr. Klinge and I really, I think we try to stray away from these generalizations in terms of percentages and numbers and focus on you and your symptoms and really try to decide what the sort of personalized treatment is for you. So just understand that there's a really large spectrum and that they all can cause different parts of tethered cord syndrome, which are the symptoms within that. So I think you want to expound on that a little bit, Petra? Or?
Yeah, the only thing that I like to add is I agree with what you said. I have to say, we were planning to maybe disagree, but here I agree. So we have the image and we have the person, right? And what dictates our decision making is the syndrome, like the clinical aspect of it. And it's sometimes, you know, we have patients that are having like imaging findings of a fatty phylum, which is consistent with tethered cord, but then they have no symptoms, and vice versa. We have patients with symptoms and that have only minute imaging findings. But I like to just say the importance is the clinical picture. And if that shows, you know, and we can talk about it more, like findings that are consistent with tethered cord, then certainly, you know, we are not just missing the cause. The fatty phylum, you know, and so terminology is where it gets confusing, and here we have to try to speak the same language. But what Dr. Greenfield said is fatty phylum, you know, is an abnormal phylum that can be consistent with tethered cord, and it's, you know, like just the evidence of that there's something wrong. But again, what dictates the decision making is the symptoms, and here we have to be very thorough in our like examination and assessment and workup, right?
Great. Yeah, totally.
Okay. There was actually something that came up in the chat that was really more of a follow-up to this, so I'm going to ask it now. Is there any type of phylum pathology that's not necessarily tethered cord syndrome? So is it possible that fatty phylum or something wrong with that end of the tethered cord of your spinal cord there could cause symptoms that might be similar to Chiari or Syringomyelia, or could it cause a Syrinx? Is there any kind of pathology that could cause something like that? So I think we're going to switch on and off. So Petra, you go first.
So if I understand the question correctly, is besides the fatty phylum, that you can see on the MRI. Is there something else in the phylum that could cause, the same thing like a fatty phylum? Is that pretty much?
Well, yes, or symptoms. So
Yeah,
pain and stuff like that.
yeah. Well, it's so as Dr. Greenfield said, there's a spectrum of what we could see in the MRI, and the fatty phylum shows us, like the obvious problem in the phylum in the MRI, but it's not always a fatty phylum. It could be a phylum that is just too thick, or inelastic because it has like a lot of other abnormal cell pathology in there. I always say we should not be forgetting the phylum terminale was once embryonic spinal cord, and it has turned into our little tail that we have all in our spinal cord. But this differentiation into the phylum, once being an embryonic spinal cord, can go wrong during embryology in many ways. And then we have all sorts of like cell junk in there, like dead cells, and this can cause a pathology in the phylum that we cannot see on the MRI. Here is where the occult scenario comes in. But anyways, to the short, there can be a lot of other things wrong with the phylum: abnormal collagen, abnormal like cell types in there, or like leftover cells from embryology times that can make a phylum structurally abnormal, and it doesn't necessarily is the fat. So there's a spectrum of abnormal phylum which is beyond the fat and beyond what we potentially can see. So the MRI is not necessarily the biomarker. But I wanted to have Dr. Greenfield add to it, because certainly here comes the controversy as to whether we would only trust tethered cord if it's seen on the MRI, or would we also trust it if we don't see anything. So yes, there are a lot of other abnormalities beyond the fat.
Yeah, this is a really it's a tricky scenario, and I think I'll throw out there like a clinical scenario that I see not infrequently, where patient will have a small syrinx in the lower end of the spinal cord, no clear evidence of a fatty phylum, but symptoms that are at least partially consistent with the tethered cord syndrome. And I find those cases really challenging, because we have to push ourselves pretty hard to figure out what other pathologies might be responsible for the syrinx. And it can really run the gamut from the top of the spinal column down to the bottom. And so Dr. Klinge went over all of the things that can occur down at the bottom that can infiltrate the phylum kind of insidiously that you might not see on the MRI. But then there's a whole other spectrum of things, like a history of infection or a small hemorrhage, scarring in the subarachnoid space. Obviously, Chiari can do it. I've seen 3 or 4 patients this year who have had a history of tumors and radiation that have caused scarring, and now have tethered cord syndrome from really physical manifestations of just, the blunt trauma of having had surgery 10, 15, or 20 years ago. So anything that manipulates the cord or the CSF spaces around it can in fact result in some of the same symptoms and syndrome of tethered cord. So it creates a real difficulty, because what you might see if you're a patient and you've got a tethered cord syndrome but no clear tethered cord is, well, do you assume it's an occult tethered cord, or do you start looking and digging even deeper? And how hard do you dig? You can do things like myelograms and flow studies, and there's a whole host of things that one might try to employ, but then it's left up to the patient and their doctor to figure out, risk benefit of all of these procedures, progression of the disease, and whether or not an exploration of the phylum is warranted. So there's certainly layer and layer of complexity here. So what looks like a really simple thing ends up becoming not just complicated and controversial, but difficult in terms of decision making, because it's not always black and white like some of the things that we see in neurosurgery.
Yeah, that kind of flows. So there are a couple of questions that came in, and I'm leading this a little bit because I know the answer. But how is tethered cord syndrome diagnosed? Is it MRI, CT? There's question about diffusion tensor imaging. I guess I'll ask, and then what is occult tethered cord syndrome? Because I know it's something that's a problem with imaging and visuals. So I guess.
Well, let me start. I'll start with the first half maybe, and leave the second half to Dr. Klinge. But the question as to how tethered cord syndrome is diagnosed, again, that really gets back to my opening story of making sure we differentiate tethered cord syndrome from tethered cord radiographically, right? So tethered cord syndrome doesn't get diagnosed by an MRI scan. Tethered cord syndrome is what we diagnose in the office by our history and our physical exam and listening to the patient's symptoms and story. Those typically include issues within the neurologic axis, so things like pain, numbness, tingling, weakness. Those are from like the nerve dysfunction, or the urologic genital urinary system, so incontinence or difficulty with bladder function or bowel function. There can be orthopedic manifestations, so some patients are born with issues with asymmetry in their feet or their legs or their gait. So those are sort of like large categories. Oh, and then skin is an important part of it as well. So what do we see on the surface of the skin? So those are like the things that we try to pull out from the exam and from the history. And then that gets balanced with what the MRI shows. So if the MRI shows something that's really concordant and we have a tethered cord syndrome, and then we have something that looks tethered, then that's really our best case scenario. And then we can make an educated decision and recommendation as to whether or not we should proceed with surgery or not, but at least those are concordant. Like what Dr. Klinge will take over for me here is, so say you've got all those symptoms, but then the MRI shows nothing, right? And then you've got tethered cord syndrome, right? So differentiate from tethered cord, and then you've got a normal looking MRI scan and the report says conus is at a normal level, no fat, and then what do you do with that?
Well, yes. The one thing is, as Dr. Greenfield just said, the tethered cord syndrome has some elements that are telling. So all what he listed is like a spectrum or a constellation of symptoms that substantiates the syndrome. So that's the good thing about a syndrome. A syndrome is kind of a unique feature that is telling that this problem might be happening. So certainly, you're sometimes a little, like you want to have more evidence of how you can further support the accuracy of a tethered cord syndrome if you don't see anything on the MRI. So there are a couple of things you can do. I want to leave out the more sophisticated MRI studies out of the equation because like a DTI study or like a Syrinx study where you can look at the movements of the spinal cord or like at some fractionated movement of water in the spinal cord. Those are still experimental. So people publish on that. There is some evidence, but I think it's yet not ready for any clinical use, but I would strongly encourage studies. But anyways, the neurological exam and is often also very telling. So often what you see in the exam is asymmetry in the neurological findings. Some weakness in one leg. I always ask, is one leg more affected than the other? That's very telling. So asymmetric presentation of pain, asymmetric presentation of weakness, reflex asymmetries, hyperreflexia in the legs, some, like clonus, which is like a foot, movement, caused by the doctor moving the ankles. These are signs that lead to tethered cord. So you have to have also like a telling exam with asymmetric weakness in the legs and abnormal reflexes. And then we usually advise, since people have bladder symptoms, to do a urodynamic study, which is not a pleasant study. I always go over this and have a thorough understanding of why we are doing this, where you can see abnormal contractions in the bladder muscle or abnormal capacity of the bladder or abnormal flow, and an experienced urologist can tackle that problem. And if there's a concern for neurogenic bladder abnormality that is not explained by anything else, those two, abnormal neuro exam, abnormal bladder study, can be increasing the accuracy to a very, high potential, which predicts good outcome and success of surgery. I think that's what we have so far. Again, imaging is still under study, and I wouldn't say that any further imaging than just our standard MRI had so far helped us to tackle the problem.
So kind of to that, because a few people have asked about this, they say sensitivity and specificity, but I'm going to change both of those words to reliable. How reliable are the tests that you can do, so the clinical batteries and the imaging that you get, to accurately diagnose tethered cord or tethered cord syndrome versus something else that might have very similar symptoms, like a Syrinx or something to that effect? So I'll let Dr. Klinge go first.
Well, I mean, the Syrinx, as Dr. Greenfield said, is probably like an indirect sign of tethered cord. So I wouldn't say, you know, like, are the symptoms caused by tethered cord or by Syrinx? As Dr. Greenfield said, Syrinx can be associated with tethered cord and might even be an indirect sign. I mean, Dr. Greenfield said also that if you have a Syrinx, certainly you have to rule out other things like hydrocephalus or Chiari or like obstruction of the spine. But if you had ruled out all the other things, then what's left is tethered cord or abnormal phylum. So I think the question is more like, how accurate can we be with this? And with a syndrome that is telling, and Dr. Greenfield summarized that, and let's say a urodynamic study that shows a neurological problem, and also like an abnormal neurological finding on exam. The exam is very important. The accuracy based on the personal experience and other studies can be up like 85 to 90% in diagnosing the syndrome. It doesn't mean that we have success of surgery, because there's another element, because tethered cord is a neurodegenerative problem. There might be some damage, but at least we can obtain quite some accuracy based on those things. And any further study on the MRI would not really, like, other than excluding other causes, would not really like increase that accuracy. I don't know what Dr. Greenfield thinks about it.
I think that's a wonderful answer, and I think one area where we're probably getting closer, and hopefully we continue to collaborate on this, is that what are the number of criteria and what are the benchmark requirements for considering a surgery in a patient who has this. And so I think that when I started my career, I think I had a much higher bar with respect to what I really needed to see, because of how we were trained, right? I don't know if that was different for you, but if you didn't have a fatty phylum and a positive urodynamics test and neurologic findings, the bar was quite high. It would have been seen as really quite off the beaten path to consider surgery in someone like that. And as we've learned more, and as our patients have taught us more, and as we've seen from each other, I think we recognize that there's probably some scale of symptoms that is enough for us to definitively diagnose it. And so either you've got the radiographic findings or you've got enough clinically. And what enough is, I think, is probably still where you're working and where I'm working, and where we're trying to figure out what's the number of things that one person needs. And I think there are some real gold standards, like Dr. Klinge mentioned. If you've got a clear neurogenic bladder from a urodynamics test, I think that holds a lot more weight for me than, say, some tingling in your feet, because I think that, number one, the consequences of neurogenic bladder not being addressed are worse, but also there's so many other possible causes for something like numbness that doesn't quite carry as much weight, but it carries some weight. And so we've got to figure out how much each of these things, the orthopedic, the neurologic, the urologic, what do they all contribute to our decision making. I think we all have our own internal algorithm, but there's really nothing out there that's published that's definitive. There's no multi-center studies. There's no randomized clinical trial data to go on. And so this is where it probably makes sense to go to someone like Dr. Klinge, who's got a lot of experience, and why I send patients where I'm unclear. I send them to her, say, what do you think? Because we're not sure what the right answer is sometimes. And so if you think that doctors aren't quite sure, you're probably right, because this isn't in any textbook, and it's still being figured out as you're watching in live time here. This is something that the patients are helping us figure out, and doctors around the country are collaborating on.
Yeah, that's great. So I'm going to wrap up the symptom stuff. this one came in when someone registered. So we already kind of went over what the symptoms of tethered cord syndrome are. Is it possible for them to cause more autonomic problems, so issues with temperature regulation or issues with heart rate? And I'll have Dr. Greenfield answer this one, and I'll have Dr. Klinge answer the next question.
That's a tough one. Thank you. Thank you for giving me that one.
No offense.
So yeah, this is I mean, it's tough, but it's fair, and I think it's fair because we do see these constellation of symptoms together not infrequently. You know, my own inclination from seeing patients who have you know, dysautonomia, so autonomic dysfunction that we believe is in the brainstem, but maybe from some of the peripheral autonomic nervous system. I think it's probably more likely that in patients who have tethered cord and who have these symptoms, that they've got something that unites those two things together. And sometimes it's a connective tissue disorder like EDS. Sometimes it's even you know, worse than that in terms of the neurologic dysfunction that's causing them. I think what the person asking the question was really getting at is whether or not the actual physical traction on the spinal cord can cause dysfunction in the brain. And I don't know the answer to that. I think that certainly there's anecdotal reports of this, and in terms of how it reflects on my own practice when patients have tethered cord and Chiari, and I think this is pretty widely adopted, that it should typically tend to address the tethered cord first, and some patients do see relief in some of their Chiari symptoms. So there is obviously some direct communication, right? These are directly connected long fiber tracts, but whether or not it's enough traction on the brainstem to cause something as insidious as dysautonomia, I'm not sure I have enough evidence to support that in general, and it's probably more related to something that unites those two things like EDS, and so they've got craniocervical instability and tethered cord, not that the tethered cord is causing it directly. But I can't say that I know that for sure, and certainly anxious to hear what Dr. Klinge thinks on that one.
I'll let you rebut, Dr. Klinge. Do you have anything to add?
Well, the only thing is a couple of things, but that's so the more, when you want to try to find answers yourself as a physician and as a researcher, you kind of, go back and find like a picture, and you're trying to make sense out of it from what you find. And there is, like there are two things. There are some studies, MRI studies, where people have looked at motion of the upper spinal cord with cine MRI before and after the cord release, and they found that there are changes in the motion of the spinal cord in the up and down movement as well as the anterior posterior movement. So it was a study in like 30 people, I think, mainly adults, and there is an indication that with tethered cord release, you also have a remote effect on spinal cord motion and spinal cord suspension at the skull base. So here you can say, yeah, there is a connection, and tethered cord is not just down on the sacral base. And the other thing is, what I found is that some anatomists had done some studies, it is what it is, on cadavers, and they looked at like the tip of the conus and where it enters into the phylum. There are cells that actually are pressure sensors of CSF pressure, pretty much what we also have in our ventricles. So the phylum might even also be a sensor of spinal fluid pressure. So the phylum and the lower base of the spine might be involved in much more like systemic regulation of spinal fluid pressure and motion of the cranial base that we thought. But here we have to have clinical studies, as Dr. Greenfield said. We cannot just like that, we have some indications that these things are real, and we should start to look into them and to believe in them, but that certainly needs scrutinized clinical studies, and we can only do that together. You cannot do it in one center. We doctors have to work together with that. In that.
That's really interesting, actually. That
yes, these are studies like from 15 or 20 years ago, and then they were just kind of sitting there, you know, and then when you look into it, and it's always like the more you look into things, the more questions you have, and then it goes all confusing. But you know, like you can straighten your head if you ask a colleague, and like Dr. Greenfield, for example, to see whether this is all like going crazy now, or if we feel that we should be designing clinical studies in order to better understand these things. But these are it's very valuable old studies, you know, and it's unfortunate that they kind of sit in the sand.
Yeah, I know, not to give anything away, but I do know that Dr. Klinge, at least, you're working on some stuff with us to kind of do some collaboration with that in clinical trials. So, but I want to switch to like etiology before because we could spiral out on symptoms, I'm sure. There was a question about, basically, there were two questions about Syrinx and the setting of tethered cord. So first of all, can tethered cord impact the size of a Syrinx in any way? And then secondly, are they always in the lumbar region, or can they be in other areas in the spine? So I'll let you go first, Dr. Greenfield.
Okay, so first part of the question was, say that again?
Size. So size of Syrinx, can tethered cord have an impact on that?
Yeah, so size and then location.
Yeah.
So I'll let me start with part two. It's a little bit easier. So that my personal belief, and I think it's a little bit better studied in Chiari, is that the typical Syrinx for tethered cord is largely a low Syrinx in the lumbosacral region, or the lumbar area of the cord, at least, unless the cord is really low. Whereas in Chiari, much larger studies have confirmed that the majority of the Syrinxes in Chiari are cervical or thoracic, although some can be lumbar. So, you know, the corollary to that would be that you could expect that the majority will be low, but that there certainly is communication of the central canal and CSF flow up and down the spinal cord. And so just as we know for sure that Syrinx in Chiari doesn't necessarily need to be right next to the obstruction of flow at the skull base, I would assume that the same holds for tethered cord, but I'm not sure that there are great large studies like there are in the Chiari world, where there are hundreds and hundreds of patients have been looked at with this respect to that question. In terms of the, but hopefully Dr. Klinge can, maybe she knows more than I do about that specific question. In terms of the size of the Syrinx and whether that's related to tethered cord, I'll just sort of, I'll answer that in a roundabout way by saying, yeah, but it doesn't really matter, right? I think that, you know, I spent, you know, an hour today with this little child who had an enormous Syrinx that was found after he fell out of a tree, and was totally fine, but they found this enormous Syrinx and he was totally asymptomatic. Everyone saw him, everyone evaluated him. So you take that scenario and you put it up against side by side, you know, with a patient who's got tethered cord syndrome and has a little 3 or 4 millimeter Syrinx. And you have to ask yourself the question of, what does it really mean? What does the Syrinx itself mean? It's an indicator that there's dysfunction of CSF flow, and it's an indicator that there's probably tethering related to it. But I'm not sure that, you know, making a decision based on 3 millimeters or 6 or 9 is all that relevant in the setting of everything we've told you tonight about how important the symptoms are and how important, you know, getting the clinical scenario is to making a decision about surgery or not. So is that a fair answer, even though it wasn't the direct answer?
I think so. Petra,
Did I get that? Anything on Petra in terms of the location of the Syrinx? Do you know data that might be more specific than what I shared?
Not for tethered cord. I agree with you that that, you know, that in our mind, you know, and that might be our bias, because it's all like down in the lumbar, we would say a lumbar or like a thoracic Syrinx is more telling. But I think we have no data to support that we should request any specific Syrinx location if it comes to tethered cord. I agree, that's not studied at all.
Okay. Well, I wanted to ask, oh, this was a really good question. And I think both of you can speak to it because you both treat adults and pediatrics. but does tethered cord look different in an adult and in a child? And then specifically in a child, how long do you wait, I guess, to see when you should seek treatment? And do you wait a while for surgery? Do you get it as soon as you're noticing some bladder issues and you have positive urodynamics? So that's really loaded question, but I'll start with Dr. Klinge.
Those are two big questions. That's not fair.
Yeah.
Yeah, well, you know, like I just start like how it occurs into my mind. Certainly, I hope that Dr. Greenfield agrees. We are very guarded, you know, to intervene in a child like younger than 4 years, I would say, because there's still a lot of developmental things. You know, the big question is always is like abnormal walking, you know, tippy-toeing, in-toeing, or like some falls that occur. Is that maybe like just you know, the delayed development, and also with the bladder symptoms. I mean, so here we sometimes have to look at the nature a little bit, and the nature can be more benign than surgical intervention. So the problem is in the very young child, are we just kind of, you know, are we too biased by an imaging and by the concern, of course, of family and other providers? So I'm guarded and tend to monitor at that young age. However, so that's one question. That's one answer, and I'm anxious to see what Dr. Greenfield says. So usually, I certainly send them to the urologist, but even here, a urodynamic study in the young kiddo is sometimes not really telling and difficult to perform. So I usually tend to monitor very closely, unless, you know, I see like a really telling abnormal exam. The second question was more like big differences between adults and children. Well, you know, different things matter to people at different stages of life. Certainly, you know, like I would say probably in a teenager or younger kid, it is like weakness and bladder symptoms. But I'd like to take it back. I think the same matters throughout life. You know, young women or older women or men, they also have like bladder symptoms, leg weakness, pain. So it's pretty much like the same concern in the patient throughout lifespan.
Dr. Greenfield.
So I don't know, we've been agreeing too much, so I'm going to mix it up a little bit here and say that I think there's a little bit of a nuance here that I think people really disagree on across the country about what to do in young kids who have fatty phylum. And it's quite interesting because I think that there are a number of ways that you can look at it. You can take positions on either side and really support them well. If you take a look at patients who have, you know, really complex tethered cords and are born with, you know, either closed neural tube defects that are lipomyelomyingoceles or the more severe fatty pathology, I think that you know, we tend to be a little bit more aggressive because we know that they're going to develop symptoms almost irrespective of you know, when you decide to detether them, and so we tend to skew that younger. And then so you can make that argument very easily that, well, if you're going to detether them and you know they're going to be symptomatic at some point in their life, then you should do it when they're young. And I think that being an adult provider as well, and seeing adults with tethered cord has changed my perspective from when I was a trainee, because I think seeing patients who have been incontinent for a decade or have had sexual dysfunction for a decade and it's been unrecognized, and then someone finally decides to scan them and finds that they have a tethered cord, leads me to believe that the opinion of some pediatric nurses that you shouldn't touch these asymptomatic fatty phylum could be wrong as well, because maybe you don't develop symptoms for 10 years, but then when you're 25 and you start doing Pilates, all of a sudden you start getting symptoms, and it's really insidious and you don't know, and then it may be irreversible at that point. So this is a great field because there's no real right or wrong answers here. What everyone should be looking for are providers that understand the full perspective and can understand both sides of the equation and help you together make those decisions, because there isn't always a right or a wrong on this. I tend to detether kids with fatty phylum when they're real and when they're robust, because I think that the risk benefit is probably in the favor of doing the surgery. But I think that that is certainly debatable, and I know even some of my own partners disagree with me on that one. So, I appreciate both sides of it, and I think I often will take the parent's perspective into account here. The difficulty, as Dr. Klinge mentioned, is that if we're going to say urodynamics are one of the most important deciding features for tethered cord syndrome, how do you know that in a child who doesn't yet have urologic, continence? And so do you wait until they're 4 or 5 until you say, well, that nighttime wetness is probably not okay, or do you wait until 6 or 7 and give it another year or two, and then you're like, whoops, too late, it was real. So it's a tough balance there, and I can't fault anyone for watching in those scenarios, but I think it's not that there's a right or a wrong, but rather informed discussion and a balancing of the risks and the benefits. So
if I can just add to that real quickly, I do agree with Dr. Greenfield. It's a balanced discussion, and so the one thing is, I certainly have to say, from my heart, I also tend to offer the surgery if there is, like a significant fatty phylum, because I always tell people, I see a lot of adults and they didn't even know they had it, and then now they're in big trouble, big time trouble, and we might then be too late and not even, like reverse the symptoms anymore. Could we have been, like preventing this if we had done the surgery when they were like little? So I do agree, but the big problem is, and Dr. Greenfield said it, is that we don't know, about anything about like the true nature of tethered cord untreated throughout lifespan. So the one thing I always say to the parents, we should be probably doing it because of the problems that it can cause, but we would never know for some amount if it was really necessary. Does that sound right, Dr. Greenfield?
Yeah, I'll share one quick anecdote of an adult, because I think we see so many kids, but I recently took care of a woman in her late 60s even, who had a fall and developed fecal incontinence that was really terrible, like really a life-altering type of condition. A little bit of pain, but it was really the fact that she no longer, after 67 years, had control of her bowels, and was going to doctor after doctor, GI mainly, and general surgeons, and a really astute general surgeon finally thought that there might be something neurologic and scanned her spine, and she had a really large fatty phylum. Also the surgeon was smart enough to send them, and we did the surgery, and she got better. And she's one of my most grateful patients ever. Like, you can change someone's life like that. But, she made it 67 years without a single problem. And so, I'm making an argument for early release, but I just, made the counter argument there. So you can't ever win in this argument.
Yeah, unless we do longitudinal studies. Yeah. Mm.
Yep. Yeah, I feel bad whenever we talk about this stuff. I always ask you these really difficult questions, and I know the answer is there's no research for it. So, but okay, moving on. I want to kind of talk about surgery. I think it's important
for patients to hear that, though, right? I mean, it's important for them to recognize that people who see this a lot still don't have all the answers, and people are always frustrated. They go to their doctor and don't get the answer they want to hear necessarily, or don't get the information they want, and it's good to go to several doctors, and I think that you start to get the impression with all of those visits that there is some controversy and some just difference in management, and that's okay, and you sort of take that all together.
Yeah, absolutely. I want to talk about surgery a bit, since you are both neurosurgeons. There was one question that I want to start with. Is fatty phylum surgery or tethered cord surgery, is that invasive, or is it considered minimally invasive in the field? I know when you're opening the skull, it's a lot, but is the spine, I know that there have been a lot of advancements in that. So I don't know if Dr. Klinge wants to go first. I think we're up to you in that turn.
Yeah, well, like certainly, like I always, it's this term like invasive or minimal invasive. It's a big, like, how can I say, like misnomer of like what we do. All things we do is invasive. And don't forget, eventually, we're gonna go and see the nerves. So it's invasive, yes. So I try to like get away from invasive and minimally invasive. And also, I would not separate the base of the skull from the base of the spine, because eventually, let's be honest, you can always create a scar. In where we are doing a surgery, and a scar around nerves is not a good thing. So two aspects how I'd like to look at the surgery. First of all, it's always invasive, but if it's a reasonable thing to do, then you gotta do it. And certainly there are certain aspects where you can control the surgery, like minimal bleeding and making it a clean and pristine procedure, which kind of avoids, like all these complications. So these are highly elective surgeries. They have to go well. So we cannot control everything, but it's invasive. But invasive doesn't mean it's a bad thing or not a viable thing. If it's controlled and you kind of do the surgery in a very controlled and stage process, then it's a surgery that has its role, and it can be done without complications.
Do you have anything to add, Dr. Greenfield?
Yeah, I think that the sort of the sentiment there is shared. I think sometimes minimally invasive is a term that's used a little bit too casually as a marketing term, and as a a selling point for surgeons to sort of woo a patient. But the ultimate goal of these surgeries is to effectively release the tension on the cord. And if it's a millimeter incision done poorly versus a centimeter done well, I think 82 out of 82 patients on this chat would choose the centimeter done well. And so part of it comes down to technology, part of it comes down to familiarity with the procedure, and going to someone who's done it hundreds of times makes a difference, not because it's minimally or maximally invasive, but because there's a routine and a familiarity and an understanding of what Dr. Klinge was mentioning in terms of keeping these clean planes and keeping blood out of the field and minimizing those potentials for retethering. So we know how to do the operation, but we're trying to take all those risk factors down from 8% to 5% to 2% so that we can make the outcome as good as we can. So don't buy in the hype with the minimally invasive. I don't want to get into sort of the different nuances of what that might mean, but in general, we all do the same procedure for the most part. There are variations in how we might approach it, or subtleties and differences that I think are probably just more training and technique than anything really meaningful in terms of the name to give it.
Yeah. So earlier, you both talked about how the tethered cord versus tethered cord syndrome are a little bit different. Are those treated differently, or are they both? Would you just do a detethering surgery for that? Dr. Greenfield's first.
So there are parts of tethered cord syndrome that you don't need to have surgery for necessarily, right? So if you've got neuropathic pain, you might want to work with a neurologist or pain management doctor and trial medications. Most of my tethered cord patients with some mild degree of urologic dysfunction will go on medications to try and improve their continence and their control. So tethered cord syndrome doesn't necessarily equate to surgery. It's when the tethered cord syndrome and the radiology really match up and conservative management has failed that you sort of get to that point. Obviously, some patients come in and they're already at the point where it's clear that surgery is necessary, but then there's a whole gray zone of patients who have really mild symptoms with mild radiology where you might want to try working with neurology, pain management, orthopedics, all the different components of what constitutes tethered cord syndrome before deciding to go forward with the surgery.
Dr. Klinge?
Well, I'd like to just bring a little bit of a different aspect to because sometimes people ask, how bad is my tethered cord? Can you look at my MRI? I would like to say that I always say, well, what is mild and what is severe is based on your symptoms. You might have a minute radiology, but you might be like having a very significant tethered cord syndrome. So mild and severe is what the patient is showing us. But the thing where I think what kind of should push us to surgery is if there's progression. I usually ask, how have you been like 6 months ago? How have you been a year ago? Weren't you having these symptoms that you are showing now? And what in your mind, not in your mind, in your experience or in your daily living has now progressed? So if there's progression and the progression is severe enough to interfere with daily life, then I think that should prompt surgery. But I do agree with Dr. Greenfield that if it's not affecting your life and if you can still go through what you want to do every day, depending on how you perceive that, you might want to try physical therapy. Sometimes like manual therapy, craniosacral therapy can help, or like some bladder medication, or acupuncture for pain. So yes, of course, every surgeon should offer like conservative management or medical management. But the mild and severe is pretty much like how your life is affected by what you have.
There was a really interesting question that just came up, and I want to get to it before we move on. Can pregnancy make tethered cord worse?
I've not cared for a patient in that scenario. I think I've certainly seen patients present with Chiari and Syrinx in the setting of bad labor or prolonged labor. I'm not sure. I've seen patients present with tethered cord syndrome after falls, as I've mentioned, in traumas, but I don't think I can recall a pregnancy. Have you seen one, Dr. Klinge?
Well, I see quite a number of people that after more multiple pregnancies have the onset of tethered cord syndrome. I do see that, I have to say, but I don't know. It's certainly the pregnancy changes metabolism and other things. I do see that. But I haven't come up with like an explanation. I had seen some females after like hysterectomy or invasive procedures, invasive again, in the like OBGYN procedures where they cut some ligaments in the pelvic when tethered cord syndrome start to happen. So I always wonder if there's some connection, in that area, but I that stressors in life, can like symptoms onset in whichever way. Just empirical. Yeah.
Sorry. So I know you haven't seen any necessarily personally, or there's not a ton of research, but would there be anything where menstrual cycle or puberty or menopause might affect any of these things?
So it's a question for me.
Yeah.
You think like so that affect the tethered cord syndrome or change after?
Change or worsen or even get better? I have no concept.
Again, so what I'm saying here is just based on things that I had never thought had any connection, but then I see it. And so I have a few ladies where the menstrual cycle has always been blamed on endocrinological things, and they actually had tethered cord syndrome, and then after surgery the menstrual cycle had improved. So I would say a handful that I have seen, and there's certainly something that needs to be reported. So I do see in ladies that there is truly a connection of menstrual cycle, changes in weight, pregnancies with tethered cord syndrome. What that exactly is, whether it's like a metabolism or like just structural, like alteration of the collagen, if we want to make that connection, I don't know, but it isn't. We cannot shy away from that because I see it a lot.
Yeah. That's
I'll add
a
one. I'll
research
add
question.
one little thing to that. In addition, is that you mentioned puberty, and I think you were hinting at hormonal issues and endocrinologic issues like Dr. Klinge was mentioning. But I think it's important to note that the populations of kids that we see who present suddenly with tethered cord syndrome often are around growth spurts, and so we know that there's this growth spurt, sort of in that 5 or 6 year range when those kids, toddlers, start becoming adolescents, and then again, obviously, in 12, 13, 14-year-olds, when they sort of shoot up 3 or 4 inches, you can imagine that if you've got a physical tether at the bottom of the spinal column, that growing 3 inches, in the summer, like we see sometimes in these these teenage boys, will all of a sudden result in issues. And so those are kids that will present with some subtle scoliosis, some subtle urologic dysfunction, new back pain. So there is some timing and relevance to that, not just the endocrine side of it, just the little physical manifestations of growing rapidly.
Very good point. I don't remember who's supposed to go first anymore, but what are some of the expectations of a detethering surgery? So I know there was a specific question about bowel functionality and how likely is that to get better, but really, what do you expect from a successful detethering? Anyone who?
Well, I'll go first on this one. I mean, I think, so expectations for surgery, I mean, I think since we're both surgeons, maybe we can spend a little bit of time talking about, the process and what it's like to go through, this type of surgery. And then, maybe I'll just make a quick mention of the bowel issue, because I think that the bowels are the sort of the poor stepchild sometimes of the urologic symptoms, and they sort of don't always get the same amount of press. And I think that I've had a fair number of patients in whom the bowel dysfunction is really the predominant symptom, and it's obviously a socially difficult scenario for kids going into elementary school, and obviously for adults as well. And so I've seen that it's often manifests as constipation, but when it manifests as incontinence, it's obviously difficult. And so those are both things that I've seen dramatically improve with detethering, so that shouldn't be ignored. In terms of the surgery, there's, I think in terms of the straightforward routine tethered cord surgery that I think is, a big part of our practices. My sort of algorithm is that it's about a 2-hour surgery, and it's about 2 days to 3 days in the hospital. I just try to keep things simple. You'll hear tons of variations in. Some people keep patients flat for 3 days. Some people don't keep patients flat at all. Some people keep people in the hospital for a week. Those are all things that you talk about with your doctor, and they can give you examples and understanding for why they choose those things. But in general, it's a small incision. Most surgeons keep patients in the hospital, keep them flat, just to allow the incision in the dura to heal a little bit, and to minimize any headaches that they might have from losing CSF from the procedure. And they're up out of bed in a day or two. So it's a quick recovery in general. It's usually tolerated quite well. And then maybe we'll save the complications and retethering things for the next question, I think.
Yeah, I'd like to add for the bowel function, I'd like to, so here I agree with that there's a fair amount and we see improvement. Also, going back to pediatric versus adult, I have a good number of adults with bowel incontinence where I was very guarded to promise any response of that to surgery, but it has improved. So also like the gastroparesis or the reflux that we sometimes see in people with comorbid Ehlers-Danlos syndrome is also sometimes alleviated with tether cord. I have to assume, like the autonomic or system is, somehow working better with like the release from the stretch of the cord. In terms of what I usually, if people tell me, like, what do you think is going to get better? So leg weakness and the feeling, that the legs are not functioning well, the fatigue is often like a very a sign that responds like early after surgery. So weakness and numbness and tingling, and the feeling that the legs are like stiffening up is often like a good a sign that responds very well to surgery. Excuse me. Back pain with the bladder, you know, and I want to hear what Dr. Greenfield has to say. We always say, you know, like that the pediatric population has a better outcome with bladder function versus the adult population, but I don't see much of a difference. I have like kids where the bladder doesn't change at all, and then I have adults with great improvement in bladder function. So I don't think that we can discriminate by age in regards to the bladder. What do you think?
Uh-oh, did she freeze? Or did I freeze?
You're good now.
Get our first malfunction. So yeah, I'm honestly, that's a good question. I've never really thought of it in that degree of detail. Did kids or adults? I tend to think in those generalities that I probably do think that kids are more malleable and more likely. Oops, sorry. More likely to respond positively to the tethering, but I'm not sure I have my own data to support or refute that. So I think you're probably right. If I look back at it, it would probably be, you know, successes and failures on both sides. I'm not sure I can speak to specific numbers on that one. I would like to ask you one question, if that's okay, Dr. Klinge, just because you had mentioned the bowel part, and so you know, we all recognize that this is something that is probably underreported and underappreciated. Do you do anything, refer patients for anything invasive in terms of manometry or any kind of testing? We do it so routinely for urologic testing, and I find that we don't often do that for the bowel side. And I know that there are invasive tests just like there are for urologic function. And I was wondering if that's been a part of your practice at all and if you found it useful.
Well, I do that if the bowel problem is like a symptom that is of major concern and kind of an isolation, because you know, in the pediatric population, the constipation or bowel dysfunction can be pretty much like the leading symptoms, and then particularly if you have like a radiographic finding of tethered cord, and the bowel problem is the leading symptoms, I usually send them to a GI doctor. But if they have like pretty much the whole spectrum, you know, of the typical tethered cord syndrome with bladder symptoms and the hemodynamic study is positive, I just kind of put the bowel problem into that box.
Right.
But if I don't see the syndrome much, and only like little pieces, but the bowel symptom, the main problem, I'm a little bit concerned that I miss another diagnosis that is conflicting. So I do send to GI doctors and do a manometry to rule out like other organic problems of the bowels. Yeah.
That's a great answer. Thank you. Yeah.
Okay. I'm going to ask one question, but before I ask the question about retethering, which you've already anticipated, Dr. Greenfield. First, can sectioning of the phylum terminale make cranial cervical instability any worse? Is there any reason that that would happen? I guess, I don't know who wants to go on that one, judging by Dr.
I mean, I can. I think that that falls under the very similar category of the question as to whether or not medullary dysfunction, you know, the dysautonomia, can come from phylum release. You know, again, I think in the absence of real data to support this and just anecdotal studies, I think we can keep an open mind and reflect on how these things may be linked. And I tend to find, again, that the link is more likely the connective tissue disorder as being, you know, one level up from both of those, and so that the tethered cord and the CCI are both related to the EDS and not that one is causative of the other. But again, I said that before, and I'll repeat that I don't really have great data other than just, you know, sporadic cases and anecdotal reports. And you know, in terms of what to do and how to manage those coexisting conditions for patients who present to me with both of those, I tend to say I tend to lead the discussion in the direction of the symptoms that are most impairing in terms of quality of life. You'll hear that phrase from me all the time in visits, is that quality of life is really what determines this. And if you've got EDS and you've got tethered cord and you've got Chiari and CCI and gastroparesis and dysautonomia, we'll tackle it all, but you got to start somewhere. And so we figure out what is the thing that is really impairing your ability to function the most, and let's start there. And if it's a constellation of things that sort of sound like tethered cord syndrome, then that's great, because that's a whole lot easier to tackle than craniocervical instability in terms of type of surgery, risk profile, difficulties down the line. But if it's not, and tethered cord doesn't sound like it's the right constellation of symptoms, then you sort of head in a different direction. But the direct link for me is still a little bit vague and blurry, but probably there's a link. We just haven't figured it out yet.
Yeah, I agree. I agree that the symptoms are, should lead you to what you have to do if you have the constellation of craniocervical or skull-based symptoms versus tethered cord symptoms. Certainly, as Dr. Greenfield said, in our heart, we always hope that, there's an element of tethered cord syndrome in this constellation, that we can offer that ahead of everything else that might need to be addressed. But we don't know. What I would like to say, and that relates to my earlier comment, that it looks like the connective tissue is a connection between the base of the skull and the tethered cord, and that particularly people with connective tissue disorders are more prone to maybe have both ways. After tethered cord release, have an aggravation of their craniocervical symptoms or improvement. Because if we believe that the suspension ligaments at the base of the skull might be affected by a release of the phylum, it can, go both ways based on a pre-existing vulnerability at the base of the skull. I would say if you have a bad angle to begin with, then tethered cord might make it even worse, because you change all the suspensions here with release of the phylum. But we have not yet found a biomarker for one or the other. And that's where Dr. Greenfield said we need to do rigorous studies. But I do believe that it can go both ways. We have to find out.
Mm-hmm. Okay, so I'm going to ask this one now, and I guess I'll start with Dr. Klinge. Why do patients retether? And does a second detethering surgery have the potential to be more successful?
So first of all, it matters what type of tethered cord you have. So as Dr. Greenfield said, it's a big spectrum. So I think in a patient with a big lipoma or lipomyelomeningocele in the classical sense, I would say the retethering is because there's still fat and pathology that you have to leave behind that adds to the potential of tethering. But I think the question is more in the scenario of a thickened phylum or a little fatty phylum, or not even a fatty phylum, why do you retether? Well, a couple of things. You always leave some phylum behind at the cord, and phylum consists of collagen. Collagen likes collagen, and so it can attach to the dura. But also the inflammation of the arachnoid, the scar that you can create, can lead the nerve to retether. So the nerves that are around the phylum can get reattached to the dura. So you can retether through a scar that was created by the surgery, or even the little leftover phylum. So so that's why you can retether. In my experience, the scarring and the retethering of the nerves is more likely to be the cause of retethering. And here I would say it's reasonable, if the symptoms relapse, to release those nerves and try to release the scar. But I'm very guarded offering a third or fourth surgery, because we learned in medical school, not medical, in neurosurgery, that you can create more scarring the more often you go back in.
I'll add to that I think that re-tethering is probably underdiagnosed quite a bit, and I've just recognized more and more that there's a reluctance among neurosurgeons to diagnose re-tethering in their own patients, which is really confounding to me sometimes. So I just see this over and over again from colleagues in the field who I think are outstanding surgeons, where they'll do a detethering for a symptom complex, the symptoms will go away, and then the symptoms come back 2 years later, and they say, no, it can't be tethered cord, you were detethered. And I've been really pleased at the success at going back in and finding problems. Like Dr. Klinge said, you will invariably find that the end of the phylum is stuck somewhere. I've seen it sewed into the dura. I've seen the arachnoid wrapped around the nerves. This is not a perfect process, and the body sometimes heals. I'll add to the comments that Dr. Klinge made that some risk factors that will increase the likelihood of scarring, in my opinion, are CSF leak. I think if you have a leak and you have inflammation and healing, I think those nerves sometimes will pull up against the dura and scar. And so if there's a history of that, I'm much more inclined to offer another operation and go back in there. And I've been fairly pleased at this. And I don't think I did this necessarily at the beginning of my career, but I've recognized it more. And I really rely so heavily on the clinical symptoms in this situation to make the decision to go back in or not. So again, that's in the scenario of like the phylum, the fatty phylum, the occult tethering, those types of scenarios. In the more complex tethered cord syndromes, the rate of retethering is much, much higher. And so if you've got a large lipoma and you were born with a defect, then those patients typically will have on average of 3 surgeries in their life. And there are some long history studies that have been published on that. And so that's really a surgery that's done with really an intent to provide quality of life for a period of time, understanding that there will be a need for further surgery at some point.
This is asked a couple of times, and I'm curious what you both think about it as well, because I know Dr. Henderson's answered it. If you have both Chiari and tethered cord, which do you operate on first? And I think I know what you're going to say, but I'm curious to see what you will. So I think I start with Dr. Greenfield this time, right? Am I wrong? I think I'm right.
Yeah, I almost always start at the bottom for all the reasons that we've discussed before in terms of sometimes, avoiding that second surgery. I do think that, as routine as Chiari surgery is for us, that there's definitely a higher risk profile. It's a little bit more invasive, a little bit more painful. And if you can avoid that, great. The second thing is that, there are patients in where, that you're going to end up doing both. And it's a question of which is more symptomatic, which is affecting the child more. They're typically children, I think, that we encounter this scenario, and for some reason, but I think I can't really come up with any large number of patients in whom I've done Chiari surgery first and then tethered cord, unless it was a scenario in which the Chiari was obvious and there was a large Syrinx and they were very symptomatic, or the tethered cord was maybe subtle, or we were unsure about it, and those tethered cord symptoms came out later, and then we decided to do the tethered cord. And I definitely know that there are patients in which that scenario was represented, but I think in general it's the other way.
Dr. Klinge?
Yes, I do agree. I agree that the tethered cord. I have also, like the majority of people that have both, I do address the tethered cord first. Only if like the Chiari is very symptomatic, and symptomatic, I mean, headache certainly can be debilitating, but release of tethered cord can sometimes also alleviate the headaches in this constellation. But certainly if Chiari, particularly in younger kids, causes like some brainstem symptoms or like health issues that are leading to like a very concerning health issue, then certainly the Chiari should be addressed in the understanding that the tethered cord might later on also be a matter of monitoring and potentially surgical correction.
I want to kind of talk about long-term management and then see if we have any time, because we are going over. There was a question about is there anything that I guess adults or children should be avoiding if they have tethered cord syndrome? Are there any types of activities? I know that they talk about this sometimes in Chiari, that some activities are restricted or less recommended. And I think I'll start with Dr. Klinge.
Well, in Chiari, you know, I really don't pose any restrictions, because it's either, you know, going to be a problem for the person or not. I mean, certainly, and Dr. Greenfield might say something, we know that sometimes after whiplash injuries or after impacts, those symptoms can be aggravated, but the science isn't good there either. And you cannot lock yourself up. So you're going to have to live our life. So that's for the Chiari. The tethered cord is maybe a little bit of a different animal, because with stressors, you know, for example, I always remember that history from the gentleman who had back pain and leg numbness and tingling, who was told he should be doing like kayaking, and he did that all summer long and was like doing it in a crazy way, and then his tethered cord syndrome started to occur with bladder incontinence and bowel problems. So you should probably avoid like repetitive like strain to your spine. But is that really preventing you from having it? Because the majority of people all of a sudden have a start after some maybe lifting and straining. But again, you cannot predict, and you cannot change your lifestyle, because I think that would be the wrong thing to do, because it's either going to work out for your life or not.
Dr. Greenfield?
I don't impose any clear restrictions. I think that if people are experiencing pain with activities, it's typically those repetitive twisting, bending things. So, you know, it's yoga and Pilates and those types of things, weightlifting. And so then obviously you have a direct history and something to guide it on. But in the setting of, you know, either minimally symptomatic or incidental, it's not, I think it's not wise to impose those restrictions, as Dr. Klinge said, because I think you're trying to, as physician, trying to help people live their normal lives. And so, you know, if you don't move or do anything, I bet you'll be less painful. That's true, but that's not the goal of, you know, diagnosing and treating. It's to try and create, you know, healthy lifestyles and provide an opportunity for people to be active. And so it's good to know if something's causing pain. That's probably more information that will help guide us in the decision-making process.
That's a good way to put it. There was a specific question that came in about managing that back pain to help maintain activity if you have tethered cord syndrome. So walking can be very difficult a certain length without having some sort of pain that the patient really struggles with. So is there something that they can do maybe holistically that they can work on to manage that pain, or is there certain meds that would work? Dr. Greenfield first.
Yeah, I love this question, because I think it's a really evolving area of interest for me. And at Cornell, we have a new integrative health service that I'm really falling in love with, because I think that it's just, you know, it's exactly what every, you know, medical center should have. And, you know, it's all encompassing. It includes pain management, of course, but there are all the things that you certainly would want for someone who's dealing with chronic back pain, whether it's due to a tethered cord or a herniated disc or chronic trauma. It's, you know, it is everything from acupuncture to, you know, psychotherapy to medical management. And, you know, that's all part of the process of dealing with chronic pain. Pain by itself from tethered cord, fortunately, I think is one of the more predictable things to improve. In my experience, and I was always, in my training, I was taught that, and I think it's borne out in my practice, that if it's an adult with back pain and incontinence, the back pain usually does really respond quite nicely to detethering, and it's the other things are a little bit more variable and harder to predict. And so if you've got back pain and an easily remediable tethered cord, so not something complex, that would be something where you might try 6 months of conservative management and something more integrative health-wise. But if it persists or get worse, that would be predictably improved by tethered cord surgery.
Yeah, that's true. I mean, the back pain, you know, certainly, you know, physical therapy, and I do tend to offer, people for the pain to see physical therapy, whether there can be some like muscular strengthening that helps, the spine to get into better alignment, and that might have an effect of the phylum pathology, maybe. So, and there are some people, that benefit from physical therapy, and kind of they hold a status quo and might not select for themselves to even undergo surgery because they don't, they think they'd rather, manage it and integrate, the symptoms into their life, which is fair. So I have high respect for physical therapists because they can really like alleviate the symptoms also in regards to the pain. But often, people then say, well, how do we go with this? So is it, if it's pain, like related to incontinence or like typical symptoms with tethered cord, I also tell people, listen, you have a good chance to have that pain improved by the tethered cord release. You might want to elect doing this, and then we can still, like work on residual pain. But physical therapy, in my view, is a very integral part of helping with the pain.
There was a question about electric stimulation, so STIM. The patient would have already been trying the medications, and STIM was sort of like a last-ditch effort to kind of manage, I guess, some of that pain. Do you go for it? Do you hold off on that, or get a surgery instead, or what do you think, Dr. Klinge?
Yeah, well, if I can start, I have seen people that had worsening of symptoms of tethered cord with electrical stimulation. So I don't know. I mean, that here might be my bias from how I believe that the phylum is causing a problem. If we think of the phylum, as a causing like bad neuronal circuits and feedback mechanism to the neurons, or even like being a bad shock absorber, I wonder whether these electrostimulation procedures, or even like some TENS or like electric shocks or whatever, are even making it worse. So I'm a little guarded, just because I see that patients get worse instead of better with that if they have a tethered cord problem.
Dr. Greenfield.
Yeah, I don't have a ton of experience to add too much to that question. I think that in general, I think that falls under the same heading of things like chiropractic, where you might sort of suggest that there could be a questionable benefit and a possible worsening in syndromes where you're doing direct manipulation or stimulation to the spinal cord. I think we tend to derive a lot of our recommendations from scenarios like low back pain in degenerative adult disc disease, where physical therapy is always thought of, and chiropractic management is really highly integrated into the care. And that's sort of a more structural issue with the spinal column. But what Dr. Klinge and I are talking about tonight is the spinal cord and neuronal dysfunction and the integrity of the connections between the brain and the peripheral nervous system. And, it's a little hard to, think that long term that doing manipulations of that or stimulations of that are going to make a huge difference. But I think we'll both agree that conservative treatments and, options to avoid surgery, particularly in the recurrent state, are always things that we'll support. But we also don't want to send people, down the wrong path if we don't think there's a lot of evidence to support it.
Yeah, that's good. All right, we're getting really late, but I have to just address one thing. So something came up in the chat. There was a conversation about maybe different techniques to doing this detethering. So I think to just clarify some of those questions, if you guys could just walk us through, what does this surgery look like? What happens in that process? And I guess in the most layman's terms possible, which I know is quite an ask. But I don't know if, I think who goes first? Dr. Greenfield first this time?
It's 60 seconds or less.
Yeah, if you can.
I think that the key parts of the surgery include that what we're trying to do is take tension off of the spinal cord and the nerves that are emanating from the spinal cord. So we're basically trying to release a tension band. And to release the tension band, you can essentially incise that band anywhere between the spinal cord and its attachment at the sacrum. So that might be anywhere L3, L4, L5, S1. There are a lot of options, and so there's variability in where people decide to do it. There might be a fatty phylum that guides where you want to do your disconnection. There may not be. Some people will try and excise part of the fat itself to reduce detethering or get specimens. Some do not. It's all done underneath a microscope for the most part, and a small opening in the dura allows access to the spinal fluid, and within which there are nerves floating around, and then the phylum. And so we can identify the phylum based on how it looks and the physiology. So we stimulate it directly, so we know we're not cutting anything that's a nerve. We simply cut it. It's most of you guys have probably seen videos on YouTube and around the internet. It's quite it's not as exciting as you might think. It's basically 10 seconds the phylum is cut, and then it's all a matter of getting there minimally invasively in terms of not doing too much damage to the muscle, not taking too much bone, closing up really in a watertight fashion to prevent leaking of fluid and minimizing infection, and then closing that muscle and skin up really watertight so that you don't get a leak. So it's a straightforward process, but there are 100 little steps along the way to get there that we've all refined and perfected and changed as we've gained experience and learned how to do this safely and to improve recovery. But that's the general sort of principle behind how we do that release.
Dr. Klinge, do you have anything to add? Or
no, only given that Dr. Greenfield gave the general overview, I'd like to just kind of do some give some nuances about technical aspects. As Dr. Greenfield said, we try to minimize the bony removal, so you can go in between those spinous processes and avoid, the facets, the joints, because you just need to go through the midline. So we're trying to avoid bony removal. And then, as Dr. Greenfield said, we're trying to do it dry. So usually, I put cottons in the field where blood cannot pool into the field before you open the dura. And then closing the dura should be you're not done with sectioning the phylum. The closing the dura is 50% of the procedure, because you want to avoid a pseudomeningocele. So I started to do a little fat graft. Once the dura is closed, I place some autonomous fat from the fascia on the suture line to seal it. But these are all nuances, because we want to avoid scars and pseudomeningoceles. But there's avoiding too much bone removal and avoiding bleeding, as well as doing a watertight closure. I think these are the elements that you have to take care of. But where to attack the phylum and how much phylum you're going to take out, that is certainly for now not something that is scrutinized in the way that we can say one method is better over the other. I like to take a piece out for histological studies, as you all know, and that's why I'm looking at that.
Well, okay, so we are super over. So thank you, Dr. Greenfield and Dr. Klinge, for getting on the call tonight. Thank everyone for attending, and I know everyone really enjoyed this, so I will tell you, I was reading the chat. And we did not get to all the questions, so I'm going to be saving the chat. And if we have another Q&A in the future, and maybe it's a little sparse on the questions up front, I can ask them in an upcoming meeting. But thanks everyone for coming, and with that, I will let you guys take a yes.
Well, thank you to you, Caitlin. Great job moderating.
I tried.
Great job, Caitlin.
It was really fun, and I think I learned something tonight too. So have a great night, everyone.
I definitely did. Thank you.
Thanks, Dr. Greenfield.
Bye, Petra.
Thank you.